Welcome to the Deep Dive. If you're a medical student trying to get your head around population health, or a professional who needs a solid scientific refresher, this deep dive is absolutely for you. We're going to cut straight to the core of what you really need to know from epidemiology, biostatistics, and public health to be, an intelligent practitioner of evidence-based medicine.
And our mission here is really clarity, actionable knowledge. We want to move beyond just simple definitions and really get to the so what of it all.
Right.
We're going to build a framework, a scientific one that covers everything from what causes preventable disease all the way to the hidden traps in research design.
Okay, so we'll start with the fundamentals of what causes disease at a population level, then walk through the 3 levels of prevention, tackle the big quantitative tools like rates and risks, and then finish up with a look at study design.
And bias.
Yeah.
And the stats that hold it all together.
Perfect. So where do we start?
Let's start with causation. When epidemiologists want to talk about all the factors that influence health, they often use this mnemonic beings. It's a great way to make sure we're not just looking at the biology.
Beings. Okay, let me see if I remember this. It's biologic, environmental, immunologic, nutritional, genetic, and the big S at the end is services, social, and spiritual factors.
Exactly. And that big S is, well, it's arguably where you have to start in public health.
Really? Why there first?
Because it covers things like lifestyle, socioeconomic status, access to care, even behavioral risks like smoking. I mean, the biggest public health wins in history didn't come from a new pill. They came from fixing these social and environmental problems.
So based on the sources, it sounds like epidemiologists actually look for those social and behavioral causes first.
Precisely. They give you the most immediate path for prevention, stuff you can do without a lab.
Okay.
Finding a pattern of, say, poor diet in one group can lead to an intervention right away. And it also gives the lab scientists the clues they need to then go look for the biological mechanism.
So the behavior points the way for the biology.
That's it. Knowing smoking is a risk factor is what guides the search for how tobacco actually damages cells.
Okay, let's unpack those real-world patterns. I want to start with that classic concept, the iceberg phenomenon. It really shows the hidden scope of a problem.
Oh, absolutely. In any epidemic, the severe cases, the ones who end up in the hospital and get reported, that's just the tip of the iceberg.
What you can see above the water.
Exactly. Below the waterline is the vast majority. People with mild infections, subclinical cases, or even just asymptomatic carriers. They're all down there.
So if your health system is only using passive surveillance, just counting who shows up,
you're getting it completely wrong.
Yep.
You are drastically underestimating the true burden, the reservoir of infection, and you won't have the resources to stop it.
because the unseen cases are what's driving the spread.
They're the engine. Understanding that is really the difference between clinical medicine and public health. It also tells us how to apply prevention, which Lavelle and Clark broke down into 3 levels.
Right, the 3 levels of prevention. Let's define those really clearly.
Okay, so primary prevention is your first line of defense. The whole goal is to stop the disease process from ever getting started.
So this is for a healthy person.
Totally healthy, but susceptible. Think about immunizations, fluoride in the water, using seatbelts. You're blocking the cause before the biology even starts.
Okay, so that's before any hint of disease. What's secondary prevention?
Secondary is when you interrupt the process before it becomes symptomatic. The key word here is screening.
Oh, okay.
You're screening a seemingly healthy person for high blood pressure, checking their cholesterol, maybe a cardiac stress test. You're trying to catch it early.
And then if the disease is already established and you have symptoms, that's when we get to tertiary prevention.
That's right. At that stage, you're just trying to limit the consequences, the physical and social damage of an established disease.
So like rehab.
Exactly. Cardiac rehab after a heart attack or treating severe hypertension to prevent a stroke. You're minimizing the damage from an illness you already have.
But that line can get a little blurry, can't it? Depending on how you actually define disease, like high cholesterol.
That's a perfect example, a perfect one. If a doctor sees high cholesterol as just a risk factor for heart disease, then treating it is primary prevention. You're preventing the heart attack.
Yeah.
But if that doctor considers high cholesterol hypercholesterolemia to be a disease in itself, then treating it is secondary prevention. You're preventing its progression. Same action, different public health label.
That nuance is so critical. Now, speaking of interventions, there's that incredible paradoxical example from history. The unintended fallout from the sanitary revolution.
Yes, it's such an important lesson that, fixing one problem can sometimes create a new one.
Right.
So sanitation improved. And infectious disease rates went way down. Great. But with poliovirus, which spreads through fecal-oral contamination, better hygiene meant babies weren't getting exposed early in life anymore.
And that early exposure used to be a good thing.
It was. Because they were exposed while they were still protected by their mother's antibodies, so they'd get this asymptomatic infection and then have lifelong immunity.
But with sanitation, they were getting exposed later, after that protection was gone.
Exactly. So while the total number of infections might have gone down, the percentage of infected kids who developed severe paralytic polio just skyrocketed.
Wow, so a public health victory accidentally created a terrifying new epidemic.
A stark reminder to always look for those secondary effects.
Okay, let's pivot to the quantitative tools.
Yeah.
We have to be really clear on the difference between risk and rate. People mix these up all the time.
They do, and it's a critical distinction. So risk is a probability. It's the chance that something like getting a disease will happen over a defined fixed period of time.
It's cumulative, from point A to point B.
That's a great way to put it. Rate, on the other hand, is different. It's more like speed or velocity. It describes how frequently an event is happening over time.
And you're saying a rate is better for measuring something like the force of mortality over a long period. Why is that? It's about the denominator, isn't it?
It's all about the denominator. With risk, you use the starting population for the whole period. A rate is dynamic. As people, say, die, they are removed from the denominator.
So the pool of people at risk is always shrinking.
It's progressively shrinking. So the rate, which uses that smaller average population, will be higher than the risk. It gives you a much more accurate picture of the intensity of the event.
Like instantaneous speed versus average speed. Got it.
Yeah.
And if we want to compare two different groups, we can't just use the simple crude rate.
Oh, absolutely not. That can be so misleading. If you compare the crude death rate in Florida to Alaska, Florida will look way worse.
That's because it has an older population?
Of course. So we solved that problem with standardized or adjusted rates.
We basically adjust the numbers to pretend the two populations have the same age structure so we can make a fair comparison.
It's essential for accuracy. And we can apply this to infant health, where we break down mortality rates to tell different stories.
Right. So we have the neonatal mortality rate deaths in the first 28 days.
And that rate tells you mostly about things around birth. You know, the quality of medical services and maternal prenatal health nutrition, smoking, things like that.
And then there's a post-neonatal mortality rate from 28 days up to 1 year.
And that one, which you get by basically subtracting the neonatal rate from the infant mortality rate, tells you more about the quality of the home environment.
Hygiene, safety, things like that.
Exactly. So those two numbers let you pinpoint if your problem is more medical or more socio-environmental.
Okay, let's quantify the impact of a specific risk factor. We need to talk about relative risk and attributable risk.
All right, relative risk, or RR, is simple to calculate but really powerful. It's just the risk in the exposed group divided by the risk in the unexposed group.
So if the RR is 5, the exposed group is 5 times more likely to get the disease.
Exactly. An RR of 1 means no difference in risk.
That tells an individual smoker their personal danger. But what about the overall public health burden?
For that, you need attributable risk. And there are two main types. First is the attributable risk percent in the exposed, or AR percent exposed.
Okay.
This is the proportion of disease just in the exposed group that's caused by that exposure. So for lung cancer, smoking accounts for about 95.4% of the risk in smokers.
So if they quit, 95.4% of the risk would just disappear.
Poof, gone.
That's incredibly powerful for a clinician to say to a patient. But wait, if that's 95.4%, why is the population attributable risk percent, the PAR percent, only 88%? That seems lower.
That is an excellent question. The PAR percent measures the impact on the total population, smokers and non-smokers combined. The reason it's lower is simply because not everybody smokes. The PAR percent is influenced by the prevalence of the risk factor. The total impact on the community is slightly diluted by the non-smokers, which brings the number down to 88%.
I see. So the AR percent exposed is what a doctor tells their patient, and the PAR percent is what a health official tells the government. It shows the biggest drains on the system.
Precisely. It's how you set priorities for control.
This leads us right into research design. How do we get these numbers and figure out if these associations are actually causal? Let's quickly contrast the two big observational designs.
Sure. In a cohort study, you start with the exposure. You take a group of, say, smokers and a group of non-smokers, and you follow them forward in time to see who develops the outcome. like lung cancer.
In a case control study.
You do the opposite. You start with the outcome. You find people who already have lung cancer, the cases, and a group that doesn't, the controls, and then you look backward in time to figure out their past exposure to smoking.
And for both of these, the golden rule is that just because two things are associated, it doesn't mean one caused the other.
Absolutely not. And the single most important criterion for causation is temporality. The cause has to come before the effect, period. If that's not the case, the association isn't causal.
Can you give an example where that gets flipped and it leads to a totally wrong conclusion?
The estrogen and endometrial cancer link is the classic example. At first, it looked like estrogen treatment caused the cancer because, well, a lot of women with the cancer had been prescribed it.
Makes sense on the surface.
But then researchers realized that estrogens were often given to control symptoms, like irregular bleeding, that were actually the first undiagnosed signs of the cancer that was already there.
So the cancer caused the treatment, not the other way around.
The temporal order was inverted. Same thing with the idea that quitting smoking causes lung cancer. It's absurd.
Right. People quit because they're starting to feel the effects of the undiagnosed cancer.
Exactly. The disease comes first, then the decision to quit.
We also have to watch out for things like bias and confounding. How would you define detection bias?
Detection bias is when you find a case or a factor more easily in one group than another. Imagine you're comparing hospitalized patients to people from the community. The hospitalized patients have had every test under the sun. You're just more likely to find subtle diseases in them because you looked harder, not because the exposure was truly linked to it.
It artificially inflates the association.
Yeah.
And then there's confounding, the hidden variable that messes everything up.
Yes, the confounder is an outside variable that's linked to both your exposure and your outcome, and it creates a false association. The study on teenage mothers' educational success is perfect for this.
Okay, remind me. Initially, they found that being older was linked to more success.
Right, which seems logical, more maturity. But age is obviously tied to grade level. Older kids are as higher grades. When they statistically controlled for grade level, the result completely flipped. Being older for your specific grade level was actually a negative predictor of success.
Because that hidden variable grade level was masking the real issue. Being older for, say, the 10th grade probably means you've had academic or social problems along the way.
And that's the true negative predictor. Without controlling for that confounder, you would have gotten the wrong answer and maybe created the wrong intervention.
It's so important.
Yeah.
Let's shift to the tools for clinical screening. When we evaluate a test, we have sensitivity and specificity.
Right. And those two are inherent properties of the test itself. They don't change based on who you're testing. Sensitivity is the test's ability to correctly find people who have the disease.
True positives.
And specificity is its ability to correctly identify people who don't have the disease. True negative.
But what the patient really cares about are the predictive values. Positive and negative predictive value.
Exactly. And crucially, predictive values are not independent of the context. They are hugely influenced by the prevalence of the disease in the population you're testing. This is all rooted in Bayes' theorem.
Can you walk us through that using the tuberculin time test example? How does low prevalence just wreck a test's utility?
Okay, so imagine you have a test that's 96% sensitive and 94% specific. On paper, that's a pretty good test. But now you use it in a population where the prevalence of TB is only 1%. Because the disease is so rare, the vast, vast majority of positive results you get are going to be false positives.
Even with that high specificity.
Even then, there are just so many more healthy people to create false positives than there are sick people to create true positives. Your positive predictive value, the chance a positive result is real, just plummets.
Which is why we don't just screen everyone for everything. For a rare disease, a good test can still produce mostly garbage results.
It's a critical concept. Now, finally, let's nail down statistical significance. We always start by stating the null hypothesis.
Which is that there's no difference. No effect, no association. The boring result.
It's the default assumption. We then set our alpha level, usually 0.05. That's our acceptable risk of making a type I error a false positive.
So that's the risk of saying there's a difference when there really isn't one.
Correct. If our calculated p-value is less than or equal to that alpha, we reject the null hypothesis and say our finding is statistically significant.
What about the other kind of mistake? Concluding there's no effect when there actually is one.
That's a type 2 error, or beta error, a false negative. We failed to reject the null when we should have. This becomes a huge deal when a study result looks clinically important but isn't statistically significant.
Why does that happen?
Most often, it's just an insufficient sample size. The study didn't have enough statistical power to detect the real difference that was actually there.
So we could end up throwing away a useful treatment just because the study was too small.
It happens, and it has very real consequences for patients. It all comes back to careful study planning.
To wrap this all up, nothing in health happens in a vacuum, which brings us to multivariable analysis.
Right. And even if you aren't doing the math, you have to be able to read the output in a journal article. Basically, it's a way to see how a bunch of independent variables, age, sex, smoking, genes, work together to explain one single outcome, like getting a disease.
And what are the main uses we see for it?
Well, there are three big ones. First, to improve clinical trials by controlling for all those other variables. Second, to estimate the relative impact of different risk factors in observational studies, like is it the diet or the exercise that matters more?
Okay.
And third, to develop the weights for diagnostic or prognostic scores that we use in the clinic all the time.
And finally, zooming all the way out, let's touch on the One Health concept.
One Health is this recognition that the health of people, the health of animals, and the health of the entire planet are all linked. You can't separate them.
So things like climate change and deforestation are public health issues.
Absolutely. They directly influence things like new infectious diseases jumping from animals to humans, antibiotic resistance. Public health is now completely tied to environmental protection and veterinary medicine.
Wow. We've covered a massive amount of ground, from beings to the three levels of prevention, rates versus risk, bias and confounding, and statistical errors. This is really the core framework, isn't it?
It is. This is the foundation you need. So for your review exercise, let's think back to that study on teenage mothers. We talked about how confounding can hide the real story. The initial finding was that older age was a positive predictor for educational success until grade level was controlled for. So think about this. Why was finding that older age for a given grade level was actually a negative predictor so important? What was really being hidden there, and what does it tell you about the real underlying risk?
A great question to chew on. The true predictor hidden in plain sight. Go out and apply this structured thinking to your studies and your practice.